Hello and welcome to another session of the Harvard Global Orthopedic Collaborative Pediatric and Oncology Conference. Today we'll be talking about pediatric infections, specifically septic arthritis and acute osteomyelitis. Go ahead and share screen. My name is Rameez Qudsi. I'm one of the pediatric orthopedic and upper extremity attendings at Dartmouth Hitchcock Medical Center in New Hampshire in the United States. So we want to begin with a common clinical scenario. A patient presents to you as the limping child. The family says, "Doctor, I have a 2-year-old girl who fell last week. Mom saw her limping the next day. Now she's not walking on that leg. What should I do?" And this is how the patient lies in the bed. So, of course, we want to begin with a workup, including, of course, the physical exam. You would likely obtain x-rays to rule out any underlying fracture, look for any lucencies in the bone. If there's any concern on exam, you would look for labs, and I would start with ESR, CRP, and a CBC with the differential if these are available. Other labs that may be relevant in specific clinical contexts would be Lyme disease if you are in, for example, where I am in New England in the United States, where that's more common actually than a deep infection or septic arthritis. But in other parts of the world, certainly you would want to think about TB and may consider sending Gene Expert, which is a pretty rapid test, as well as HIV if that is prevalent in your area, looking for immunocompromise. If the child has fevers and a limp, I would recommend, if able, sending blood culture. Sometimes that can get you a sample prior to any others. So specifically on the exam, you want to make sure to focus on the full extremity, hips to toes, any pain with range of motion, isolating different joints. So performing log roll while the patient is lying down to assess the hip, and then looking specifically for effusions at joints that are visible, such as the knee and the ankle. Lastly, looking at point tenderness throughout the femur, the knee, the tibia, and down to the foot itself. Sometimes incidental trauma can be isolated with just some point tenderness and then a focused x-ray rather than x-rays of the entire extremity, which can be wasteful. Lastly, if an ultrasound is available, and then you can use that to check for effusions as well in the knee, ankle, especially though of the hip. I think it is most useful in the limping child assessing the hip itself to look for effusions. It can also help guide any aspiration. We all may have heard about the Coker criterion. This is certainly internationally used, and I want to just point out that it was developed to evaluate specifically hip septic arthritis. It was used to distinguish or try to distinguish between a hip septic arthritis, which would need obviously an urgent intervention, versus other things like transient synovitis or just pain or trauma or incidental findings. The criterion that a temperature greater than 101.3 or 38.5 Celsius, refusal to weight bear, white count greater than 12, and ESR greater than 40. The sensitivities of this criterion: if 2 of the 4 only are positive, that's 40%, 3 is 93%, and if 4 are positive, 99%. Now, I want to point out what that means is if a patient, like the one in front of us, has septic arthritis, then there's, for example, a 93% chance that 3 of these things will be positive. The positive predictor value, though, of the test is maybe around 59%, depending on one of the studies. And what that means is if the Coker criterion are positive, then there's about a 59% chance that the child has septic arthritis. So just keep that in mind with these numbers. But at the moment, this is one of the most relied on criterion. Later on, Dr. Caird and her group did add on the CRP, which we all know is very important to check and is a good indicator of inflammatory or infectious disease. So if the CRP is greater than 2 and you have all of the other ones, then there's a 98% sensitivity. The other numbers are as follows. So in the modern era, I would definitely advocate having a CRP. In fact, of the labs being sent, I think the CRP is likely the most important. So back to our clinical scenario. This child's temperature, let's say, is 39, and they're still refusing to bear weight on the right. One of the important things to note, we were mentioning exam before, in this clinical photo, you can see the position of the right leg. It's in this flexed abducted, somewhat externally rotated position, this Faber position. That is a position actually that will relax the hip capsule the most. And so if there is swelling or effusion, this is typically how a child, if they're lying down, will be. Here are some representative plain films. And what's being pointed out is a subtle indication of perhaps a hip effusion. And specifically, if one looks at the distance between the femoral head and the acetabulum, you can see that there's a difference right to left. And that can be a subtle indicator, even on an x-ray, of a hip effusion. Doesn't mean they have septic arthritis, but it can be of a hip effusion. So then an ultrasound is performed. This can be a very cost-effective way to actually look for these things. As I mentioned, look for effusion, good screening test, help guide aspiration, essentially reusable parts. And so those who have the ability to either train on ultrasound or obtain an ultrasound machine, I do think it's a pretty helpful adjunct in the orthopedic and emergency room. So on the right side, you can see there and effusion compared to the left, it's always a good idea to check both sides to look for differences. It can be confusing, especially if the child is moving. It's helpful to have a comparison on both sides. Now, at this point, we know the child has an effusion. In and of itself, that could be transient synovitis. It could be a sign of underlying trauma. However, we have a child with fever, effusions. I would advocate at this point to go ahead, of course, with those labs. And then if COCA criteria are met, or even if there's at this point just a clinical suspicion, again, it's okay to just go ahead and aspirate the hip so that you're not missing anything else. I think better if the child's in front of you to do the full workup and treat accordingly rather than hope and wait. In some contexts, you can wait and clinically monitor for a day or two, but in reality, that time may not always be available, and that is time out of work for families. So the sooner you can get a diagnosis, the better. At this point, the differential would be septic arthritis, transient synovitis, injury. Malignancy is always on the table for anyone coming in until proven otherwise. Again, Lyme disease in those parts of the world where that's more common, and osteomyelitis, which can happen with septic arthritis. And that's something we're talking about later as well in this talk. So options for the next step here would just be going straight to the OR for an IND and then sending cultures. You could aspirate the hip with or without ultrasound and then send the culture. You could also do an aspiration with lavage, which is a historic and known treatment for septic arthritis of any joint, is just aspirating and irrigating and doing this perhaps a few times until the patient is better. And there are some studies showing that it has equal outcomes to operative washout. However, the downside, as you can imagine, is there can be a slightly higher rate of recurrence or need to go to the OR with just aspiration. But it's an option, especially in a situation if someone isn't able to get to the OR early enough. Lastly, for those who have this available, there is debate about MRI prior to washout if someone presumes septic arthritis. This is, of course, if the machine's available, but also even in higher income settings, it's only a real option if the machine is available quickly. Most people would agree you don't want to delay washing out an infected joint to get the MRI to assess for underlying osteomyelitis. But if one can get it quickly, or if it's not there isn't a plan to wash out a joint quickly, or if the clinical suspicion is really high for osteomyelitis. One thing that can help distinguish the two is not just the labs that we talked about, but specifically the level of pain and how the exam is. We had a patient recently who had a swollen joint. In this case, it was a knee, and was moving it, ranging it, but was having some intermittent refusal to weight bear, no high fevers, but just a lot of pain on exam. And so at that point, we did recommend an MRI to look for underlying osteomyelitis before just going to the OR to wash a joint out, which can then delay an MRI or change the findings. So in some settings, that's useful to do before surgery, only if you can get it quickly. Otherwise, I would advocate just treat the joint in front of you. So I want to talk about why, again, in some joints, this idea of osteomyelitis with septic arthritis is relevant. So in specific joints, as a review, the capsule itself includes the metaphysis of the joint. So as we look at the hip here, we can see This sort of cartoon drawing is showing how the capsule comes down into the metaphysis. And we know that the metaphysis is where often there's seeding with bacterium if it's a hematogenous spread because of the smaller blood vessels, the capillaries, and then the physis. And so if you do have seeding and if you do have osteomyelitis, that can break out into a septic arthritis, or even vice versa. If you have a septic arthritis, it is in contact with the metaphysis for seeding. Whereas in the knee joint, the capsule really isolates the epiphysis. The metaphysis is not inside the joint capsule of the knee. And so the chance of having a knee osteomyelitis concomitant with septic arthritis is much lower. So the joints in the body in which it is common or more likely to have osteo of the metaphysis with septic arthritis are the shoulder and elbow, the hip and the ankle. So let's talk a little bit about septic arthritis more formally. Our patient, we did the aspiration, and then we can go ahead and assume that they did have septic arthritis. The etiology, it's mostly hematogenous. Less common etiologies would be traumatic event or an actual injury that sometimes can have a mechanical disruption leading to a septic arthritis. Obviously, penetrating injury into a joint can cause this, so it's much less common. And then iatrogenic, if there's any kind of surgery in and around a joint, that can result in a septic arthritis. In children, certainly hematogenous is what we're really looking for. It has been shown that it's much more common in males than females. It is typically really young children, depending on your region and location. It can be almost half of these cases in 2-year-olds or younger. Certainly, there's an increased risk if one is immunocompromised, has sickle cell or hemophilia. We should talk about the pathogens or the bugs that are common. This changes based on region. And so obviously there's a lot of room for research to be done in different parts of the world to look for what is the profile, the pathogenic profile in your specific area. And so these are some of the common historical studies under 3 months. Really in all of them, Staph aureus is what we're thinking about up front if you're just empirically treating, but also group B strep and Neisseria, gonorrhea, and newborns. In the most common 3 months to 5-year-old, Staph aureus is certainly the most common, whether it's MSSA or MRSA, but Staph. Kingella has a sort of an increasing importance nowadays, especially with other things like Haemophilus influenza decreasing in the setting of vaccinations, if that's being offered. But Kingella has to be thought about now. Group A strep is just less common. And then older than 5 years, again, Staph aureus will always be the number one. And in sexually active patients, thinking again about Neisseria gonorrhea. This is just a representative algorithm. It's one that I like on just if you have a clinical suspicion of septic arthritis, just having a protocol. In areas where maybe orthopedic officers or orthopedic physicians may not be available all the time to examine the child, this can be a reasonable way to guide other clinicians that if there's concern, doing the physical exam, getting the x-ray and labs, if there are 3 or 4 in terms of Coker criteria or an isolation, a CRP greater than 2, then going ahead with aspirating the joint if they are able to with or without the ultrasound, and then moving forward with the idea of a surgical debridement if all of those things are positive. But if there's no joint effusion, then that can be something that can often be managed clinically by non-surgical providers. So in our case, a aspiration is performed. We will say there's an 80,000 white count, which generally anything above 50,000 you would consider washing out and presume septic arthritis. And then you go ahead to the OR. This is again just a representative image about an anterior hip approach, which is typically how I prefer to do the washouts of the hip. Direct anterior approach, opening the capsule and making sure that that capsule remains open at the end, thoroughly irrigating with several liters of normal saline, really until the joint fluid and all the fluid coming out is clear. It's helpful for positioning to have a little bump under the hip, I find, and also you can choose incision. Straight longitudinal, this more cosmetic bikini line also works really well. What next then about antibiotics? So certainly culture should be sent. either from an aspiration, and then one can begin antibiotics, or from the OR getting your cultures. But once cultures are obtained, it's not necessary to wait until the cultures are returned to begin antibiotics. And if cultures can't be obtained, it's okay to begin empiric antibiotics if the patient is afebrile or becoming at all unstable in any way. So empirically, if you're in a region where Staph aureus is the most common, which is most places, I believe, you can certainly start with oxacillin or cefazolin. If you're in an environment where MRSA is higher, or the patient in front of you may have had multiple infections in the past, multiple hospitalizations, things like that, then can try clindamycin. Vancomycin is available and certainly a good adjunct if there's clinda resistance, either known in the patient or in the region to be greater than 10%. The chart above here just indicates if different ages, what someone might start with. Most patients, I would start with some coverage for MSSA with or without vancomycin. After the joint itself is washed out, let's say you've presumed the infection, how long do you continue the antibiotics? So IV antibiotics is typically recommended for 2 to 7 days. There's different studies showing 2 versus up to a week. So I would say at least a few days. And then I would use clinical judgment based on a few criterion to convert to orals. So really, it's you want to see the patients improving on IV to confirm that there's been adequate treatment with the surgery for washout, as well as adequate choice of antibiotics. Once the patient is clinically improving, meaning no longer febrile, they're more mobile, they're allowing a better examination with range of motion of the joint, then it's okay to convert to oral antibiotics. A lot of people do advocate, and if you have this available, then I would do so, is getting every day or every other day a CRP to see if that's improving. Once that does improve significantly, it's also okay to convert to oral antibiotics, and they should be continued at least 2 to 3 weeks. Let's switch gears now to osteomyelitis. And again, the focus here is generally just on acute. Our cases in this conference will focus more on the chronic side, where we can have more of a discussion on that. So in general, within a few days to a week, I would consider acute osteomyelitis, subacute in the weeks to 3 months, and often, if not most of our patients, might be in that subacute to chronic range. Chronic, we can say, is more than 3 months. So patients with acute osteomyelitis, the etiology is once again usually hematogenous for the reason we talked about before, where those blood vessels are branching out into those capillaries in the metaphysis and at the physeal level. It can be from trauma, most commonly open fracture, or it can be iatrogenic. Again, if there's any surgery, then this can increase the chance of getting osteomyelitis. It's usually, again, in younger children, though maybe less than 10 years old, but all older children are also seen commonly with acute osteo, especially in the setting of trauma, open fractures. Older children are more active and more likely to get these injuries. They can be indolent, hard to diagnose, hard to know exactly what's going on. Patient can have very mild symptoms for a while until it becomes more clear. And again, it's often associated with trauma, both in the setting of open fracture, or there are some thoughts and theories about the actual mechanical injury of even a closed trauma, whether it's through sort of seeding from elsewhere in the body or an incidental finding. In the case vignette earlier, we presented a patient who had a fall because a lot of children have falls, a lot of children have trauma. And so even if you're presented with a child who has trauma and pain, it doesn't always mean that this is a fracture or a traumatic injury. One must always keep in mind that the trauma might just be incidental. In fact, the pain may be from an osteomyelitis. The patient happens to just have fall, and that's why they're coming in. CRP and ESR remain the two mainstays in terms of labs, along with the white count. Again, CRP is faster on and off. This chart just demonstrates that the CRP will go up within days, but also come down very quickly in treatment. And so that's where if there's one test that you're limited to, I would advocate getting a CRP. ESR can tell you sort of in the long haul. So if a patient comes in and a CRP is negative, but an ESR is high and elevated or positive, then that may mean that they did have an issue some time ago in the subacute period, but it's resolving now. So both of them work together. CRP can give you the most immediate clinical benefit. Let's talk about treatment of osteomyelitis. So initially, there may be no bony changes or lucencies or any changes on X-ray. There may be no what we call subperiosteal elevation or abscess. So it's important to know that if you're actually catching an acute osteomyelitis before it's surgical, there is a role for empiric antibiotics and medical management. And that would be patient maybe perhaps febrile, they have point tenderness, no septic arthritis at this point. If there's an MRI available, then that's great. One can get an MRI to look for the signal in the bone, meaning that um, increased signal on T2, specifically looking for swelling or edema. If this is the case, empiric antibiotics can be started, even without a culture. The role for the orthopedic surgeon is usually if it's to the point where there's an abscess to drain or bony changes to address. However, some orthopedic surgeons may consider a needle or open biopsy just for cultures if the patient is not getting better on empiric antibiotics. I think that does make sense, though it's much less commonly done. And also if you're concerned about malignancy. So obviously check all infections for tumor and check all tumor for infection. If on plain films you do have any of the above findings, specifically a bony lucency as is shown here, some element of abscess either in the soft tissue or more commonly a Brodie's abscess, which when it gets to more subacute chronic phase, subperiosteal elevation can be an indication of an underlying abscess as well. We have to be careful. That can also be an indication for underlying tumor. And so if one does go in for drainage and sample and culture, send it for culture and pathology, but also taking an approach that would be amenable to a tumor surgery later if it turns out to be a tumor. In children, of course, Ewing's and osteosarcoma will be the ones someone is most worried about if you're seeing this subperiosteal elevation. Those patients can also have pain, inflammatory markers elevated, limp, as well as fevers. But if you do see these findings on an X-ray and the patient does have a fever, they do need to go to the operating room for operative management as well as the antibiotics. So operative debridement would include a through soft tissue and muscle approach to allow for coverage, meaning you want to avoid incisions that are directly over bony prominences. For example, the medial tibia would not be a great place to access the bone because there's not much coverage there, and you worry about soft tissue defects. So going through an approach where you do have muscle overlying the bone when you're done to reduce the chance of a soft tissue problem. Drilling into a bone to just relieve an abscess and flush is reasonable. You can also debride any exposed necrotic bone if this actually looks more chronic than acute. Draining the adjacent joint if the osteomyelitis is close is again a reasonable thing. If the exam or labs are limited and you're just not sure, but if the patient has pain with motion of that joint, there's very low risk to actually performing an IND of an adjacent joint to just try to increase the odds of the patient getting better and not needing to return to the operating room. Sometimes it can be difficult to distinguish septic arthritis versus osteomyelitis, and it's reasonable to just go ahead and treat both, particularly in the joints we talked about earlier, where there's a high rate of them being together. So shoulder, elbow, hip, and ankle. When debriding bone or drilling into joints, if there is a frank abscess, a good technique is leaving antibiotic cement behind for slow delivery of antibiotics inside as well as systemically. A common way to do this is to pack small antibiotic beads around a string that can be removed later at a subsequent surgery. Packing that in, it is visible on X-ray as well as easy to find later. And this can be packed into small cavities or even around the bone if there's an abscess. And I advocate doing that. The antibiotics can be selected based on what's available in your area, the bugs that are typically there as well in each region. Often people are using vancomycin or tobramycin, but it really depends what's available. And the other thing is using antibiotics that are okay in heat because the antibiotics, as it hardens, will let off heat. And so that requires using the form of antibiotic that doesn't get damaged with heat. This is a similar presentation from before with osteomyelitis as well as septic arthritis. A reminder to just start empirically with oxacillin, can use clindamycin or vancomycin if needed. For osteomyelitis, however, the difference is typically people are doing about 6 weeks of antibiotics for osteomyelitis. Again, you're monitoring for improvement clinically. You can use the CRP and CBC to monitor for that improvement. And if the patient's not improving on one antibiotic, it is important to change and obviously continue to follow cultures if you have sensitivity data that are coming from the cultures. If the patient is not improving clinically, in addition to changing antibiotics, it is also important to consider a repeat washout. It's not uncommon to need several washes or looking for other sites. Rarely, you can have infection in multiple regions of the bone, or even in very rare cases, multiple sites. Here's where I'll mention something: chronic regional multifocal osteomyelitis. It can be a confusing term. It's actually a disease where you don't typically perform operative washouts, where there's multiple areas that look like infection in the bone in multiple bones. That can be a red herring. It's really uncommon. At the moment, for today's purpose, we'll focus on true osteomyelitis, but just be aware that that's available. If you have a patient, though, that you've washed out and it's not getting better, then I would recommend for, again, areas where a bone scan is common, that can be done. Most of us are just doing repeat x-ray to see if anything is worsening, MRI if it's available, or simply return to the OR, a repeat washout, perhaps additional drills into the bone, perhaps washing out that adjacent joint, and also changing the antibiotics along the way. Thanks for your time today. Hopefully that was a helpful discussion, and I look forward as well in this conference and these sessions to some interesting cases.